Good morning, everyone. I will primarily present unpublished data. So maybe if I can do the first of the presentation while you're recording, and then when I say stop recording, is that something that we can agree upon? Perfect. Okay. So my name is Rikke Møller. I'm a geneticist, professor of epilepsy genetics, and head of Department of Epilepsy Genetics and Personalized Medicine at the Danish Epilepsy Center, and I'll be talking about the clinical presentation of GABA-A receptor-related disorders. So this is our Danish-Australian team, GABA-A receptor-related team. So as I mentioned yesterday, we are located at 6 different institutions in Denmark and in Australia, and we met up in Denmark in May this year. And then we have expanded the collaboration a little bit outside of Denmark and Australia, and we now have collaborators. It's not working that well. Okay, and so now we have, as Juliet was presenting yesterday, we are collaborating with Juliet Novels at Stanford University, Dennis Lal at the University of Houston, and then I will present data on GABAAR B1 in a study led by Sarah Weckhuizen and Charissa Millevert from University of Antwerp. So it's like one big GABA-A receptor-related research team family. So this is our project that we are running. It's called From Disease-Causing Variants to Targeted Therapy in GABA-A receptor-related epilepsies. So there's a clinical team that's doing all the clinical workup. That's our team at the Danish Epilepsy Center. Then the team at the University of Sydney are doing all the functional assessments, and Nathan will present some of the results later today. Then in working group 2, there we have Chris and Pew from Florey in Melbourne. They are making mouse models of primarily gain-of-function disease, and Pew will present some results there. Then the mice are shipped to Copenhagen in an airplane, and then we are working also in Copenhagen on these mouse models that were generated in Australia. Then in Denmark we have stem cell models of both gain and loss function disease, and then we are all working together in AIM4 to try to find new targeted therapies for individuals with GABA-A receptor-related disorders. So, yeah, so we made a clinical database at the Danish Epilepsy Center where we have now collected data on more than 900 individuals with a GABA-A receptor-related disorder. So the most common genes that we are aware of are the gamma-2 subunit, followed by variants in beta-3, alpha-1, and then beta-2, and then we have some more rare variants found in alpha-1, or alpha-2, alpha-3, alpha-5, beta-1, and the delta subunit. So we have also been looking into the incidence of what is the incidence and prevalence of GABA-A receptor-related disorders. I calculated that in the Danish population because the Danish population is easy to work with. We are very few people. We are less than 6 million people in Denmark. We have good registries. We have a strong tradition for doing genetic testing. So I calculated the incidence of GABA-A receptor-related disorders. So I took 3 genes, some of the most common genes, alpha-1, beta-2 and beta-3, and I looked at all kids born in Denmark between 2006 and 2017, and I found that the incidence is around 1 in 66,000. And there are approximately 60,000 kids born in Denmark per year, meaning that there will be 1 child born with this condition per year in Denmark. And then I looked into the birth rates in US, and it means that there will be, with these 3 genes, then there will be approximately 60 kids born in US per year. So there should be around 1,000 kids below the age of 18 years with these 3 gene defects in US. And we do not have in CURE GABA-A, nor in our database, 1,000 kids below 18 from US. So we need to find these kids. So we need to ensure that our colleagues are doing genetic testing in all patients that could have a GABA-A receptor-related disorder. So that's why each time I have the chance, I'm telling when and where to consider genetic testing, and genetic testing should always be considered in individuals with early onset seizures, regardless of whether there's delayed development or not. So if a child has seizures before the age of 3 to 4 years without any other obvious explanation, then genetic testing should be considered. The same should be considered in all individuals where you see intellectual disability, autism, or other neurological comorbidities. Then genetic testing should be offered or at least considered. And then we have a whole other groups of epilepsy patients that are eligible for genetic testing. Not all epilepsy patients are eligible for genetic testing. It's highly depending on the age of seizure onset. If the seizure onset is early in life, then the chances of finding a monogenic condition is very high compared to if you have seizure onset later in life, then it's more a polygenic condition, and you won't find a gene that can explain the symptoms. So in our database, these are the informations that we are collecting. We are collecting information about the genetic variant. We have information about what our colleagues in Sydney have found in their functional assessments. We have information about demographics, about seizure semiology, early developmental milestones, epilepsy syndrome, sleep disorders, cognitive outcomes, neuropsychiatric features. We are collecting raw EEGs, we are collecting MRIs whenever possible, and so on. Because an epileptic encephalopathy is much more than just seizures, and we need to look also at these non-seizure outcomes when we are doing research in these conditions. So we're using all these informations to do genotype-phenotype correlations. I won't go into depth with this slide because I know that Nathan will present this study in his presentation as well. It's just to show you how we're working. So we're grouping them into loss of function, gain of function cases, and then we are trying to delineate the phenotypic spectrum. And this is for beta 2. And as you can see, there's a high risk of developing seizures, but not all are developing seizures, neither in the loss of function group nor in the gain of function group. There's still only around 90% that are developing seizures, meaning that 10% are having a neurodevelopmental disorder without developing epilepsy. So we also, when new trials are coming up, we also need to capture these non-seizure related outcomes. We found in this study that there was also a high correlation with the disease severity and the functional effect of the variant. So the stronger the gain of function that Nathan and Philip found in the lab, the more severe the phenotype. And for those with beta 2 that had the strongest gain of function, there we saw an very early seizure onset and an increased mortality compared to those where the gain of function effect was less severe. And now I'll stop recording.
Thank you, Rikke, and thank you all for the organization of the meeting.